Now I call upon Dr. G.S. Wander to introduce the next speaker. Dr. G.S. Wander, I think he has logged in.
Yes, sir.
Yeah, please introduce the next speaker, Professor Dr. A.B. Mehta.
Well, very good morning to everyone. And Dr. A.B. Mehta needs no introduction. We all have known him as a very astute analyzer of data, and his contributions to India Live and interventions all across the country are well known to all of us. It's always a pleasure actually to listen to Dr. A.B. Mehta, Dr. Mehta, because I can still recollect, I'll just take half a minute of yours. Many years back when electrophysiology came up, actually, he was giving a talk on the rhythm abnormalities. And he showed us, that time we were not very familiar that these are the catheters that they put in. And he also showed us a catheter down under because the procedure at that time used to take a long time. So he advised, such is the humor and wit that Dr. Mehta attaches with the medicine. And so it's always been a pleasure to listen to you, sir. Over to Dr. A.B. Mehta, please.
Thank you very much, Dr. Wander. Here is, I'm trying to show you something. I enjoyed all the talks. Wonderful. Starting with Dr. P.C. Manoria, who showed full of evidences to create a platform for modern clinical therapy. Though from those evidences, how do we apply those evidences into our clinical practice by appropriate and optimal usage of pharmacotherapy? And besides that, when the pharmacotherapy is reached its end stage, how do we go forward to mechanical treatment of heart failure? 6.2 million adults in the United States have a heart failure, and the median survival of them is 2.4 years from the date of diagnosis. 21 in every 1,000 after the age of 65 years have a heart failure, and by 2030, 8 million adults. Now, these figures could be much higher in India, although reported Indian literature shows 2.1 million. I think it is highly, highly underreported. The reason being that we do not have an appropriate system of collecting data. And every heart failure hospitalization increases your patient's risk for death. After the first hospitalization, median survival is about 2.5 years. After second, it drops to about 1.5. And after the fourth hospitalization is 0.5 years. That means 6 months after the fourth. That means it's a progressive disease, especially in the absence of any functional or structural disorder. Now, clinical profile of the heart failure patients. There are 3 stages, 3 classifications. ACC classifies as stages. NYHA is as a functional classification, which we use very commonly in our clinical practice. And Intermex profiles is being used by the therapist who provide the mechanical supports and mechanical circulatory supports or even a heart transplant. So, but beyond ABC stages 3 or ABC stages C or NYHA classification beyond 3 or Intermex classifications beyond 7 are severe, serious heart failure patients. So changing paradigm in the treatment of heart failure is very evident. In 1920, we had only diuretics. And today in 2022, we have ARNI, SGLT2, LVAD, Ecmo, and heart transplant. So heart failure with reduced ejection fraction stage C, we have a combination of treatment, ARNI, ACE inhibitor, and ARB. ACE inhibitors and ARB should only be used when it is considered that there is serious contraindication or intolerance to ARNI, because ARNI has now replaced ACE and ARB. Evidence-based beta blockers. There are 3 of them, carvedilol, metoprolol, and bisoprolol, and all of them have been found to be more or less equal effect in management of heart failure, and with diuretic agents as needed. Now, in addition to that, I'm just talking now in the clinical practice for patients who have eGFR of 30% or less, 30 ml or less, or creatinine level less than 2.5, or in the females less than 2, then I think one can add MRA. In addition, we heard a lot about SGLT2, and for patients who are meeting with the eGFR criterion and those who are in class NYHA 2 by 4, I think one can profitably add SGLT2. And as already spoken by Dr. Chopra, that it should be in a staged fashion, sequentially, not simultaneously. And for those patients who also show volume overload, congestion, you should titrate and use them in diuretics also in addition. And for persistently symptomatic patients, especially the Black population, is well reported there that combinations of ARNI, beta blocker, MRA, SGLT2, and in addition to that, one may benefit by adding hydrolazine and isosorbide dinitrate. When after the adequate and maximum usage of beta blocker is already achieved, then even then, if the heart rate is not in the optimal level, between 60 and 70, then I think evaporated a day. At this point of time, let me point that there are 4 important factors which increase the left ventricular work: preload, afterload, heart rate, and beta stimulations, or the status of the catecholamines. Now, we have to target all this to optimally treat the heart failure. Now, key changes in the treatment recommendation for heart failure patients is the ARNI. ARNI is the preferred first-line renin-angiotensin antagonist in heart failure with reduced ejection fraction. For those patients in whom ARNI administration is not possible, ACE and ARB is recommended, all right. SGLT2 inhibitors are added in as part of the therapy for patients with chronic heart failure already receiving beta blockers, ARNI, ACE, and ARB, and aldosterone antagonists, and whenever they are contraindicated. Well, I will not discuss this slide. I think a lot of data has been already discussed by Dr. Manoria. Now, sacubitril and valsartan combination along with the beta blocker and MR in heart failure patients shows superior reduction in mortality. Combination of all those three has a reduction in mortality by 63%, and then subsequently you see that merely when there was a time when we were using only ACE inhibitor, the mortality reduction was very low as 17%. Now, the advanced therapies for the heart failure patients is initially when they are just congested, relief of congestive symptoms, maybe by the loop diuretics. Then when the ejection fraction is 40, right. So when the ejection fraction is less than 40 and the patient's in NYH class any, 1 to 4 any, I think we already learned that ACE inhibitor, ARB and ARNI and ACE and ARB cannot be used together for the simple reason of a fear of angioneurotic edema. Beta blockers and SGLT2 and MRA, and they are still symptomatic. I think we should consider mechanical circulatory support, including left ventricular assist device and heart transplant. CRT. My usage of CRT with pacemaker is considerably reduced after the development of a recent pharmacotherapy. And there have been patients of mine who had the ejection fraction of 15 to 20% with class 3, and they have improved with the pharmacotherapy that just mentioned to a class 2 to class 1, and they have lived comfortably for several months together. And there, I think the need for chronic resynchronization therapy with pacemaker has gone down. The benefit is greatest in patients who have a left bundle branch block, ventricular dyssynchrony, and QRS complex width is more than 150. Moreover, people who have the class 3 and class 4, they do not benefit much. It is those who have in class 1 and 2. It is quite possible to be able to bring patients of class 3 and class 4 to class 2 and class 1 by appropriate combination of an optimal pharmacotherapy, including SGLT2 and ARNI. Then comes the people who have, despite all the medical treatment, have no response or starts showing deterioration further. In such patients, we have to have mechanical circulatory support. Some are on the temporary basis, especially for the reversible disease, like for example, viral myocarditis or a reversible cardiomyopathy or some kind of structural or functional heart disease for which the definitive treatment could still be available. We know arterial extracorporeal membrane oxygenator is in the management of heart failure found to be very, very supportive. Indications are cardiogenic shock secondary to acute coronary syndrome, where we feel that the stunned myocardium is likely to reverse and recruit and improve the situation. Viral myocarditis. Some of my patients who had viral myocarditis in whom even the cardiac transplant was being thought about, I think they improved a lot after managing them in Ecmo for several weeks and sometimes even a month or two. post-cardiotomy cardiogenic shock. And I think that also is a reversible situation. When the stunning mechanism goes away, patients can have an adequate left ventricular ejection fraction, and transiently we can bail them out with using an Ecmo. Any two criteria observed over a period of 4 to 6 hours, like refractory arrhythmia, cardiogenic shock with high inotropic requirements, lactate level more than 5 millimoles, poor tissue perfusion, that means cardiogenic shock-like syndrome, cyanosis, metabolic acidosis, oliguria, intra-aortic balloon support, along with the inotropics. And if that is so, then I think the Ecmo is indicated. What's the basics of Ecmo? It's a modified cardiopulmonary bypass, can work for days and weeks together. The centrifugal pump withdraws the desaturated blood from the IVC and SVC, or sometimes from the lower right atrium. It oxygenates it outside the body, and then it is redirected into the circulation, most commonly through the femoral artery. The common adjectives for VA and Ecmo is the bridge to recovery, or bridge to decision making, where the patients are being for the heart transplant or whatnot, bridge to bridge, and more commonly bridge to transplant. And these are the various temporary mechanical circulatory supports. We have 4 of them: IABP, Impella, Tandem Heart, and LVAD. Now, there are various mechanisms, there are various benefits and various disadvantages. The commonest one which is being used is IABP, because A, it does not require a cath lab support. It can be done bedside, very easy to administer. 3, it has a minimum side effects. And the 4, it is widely used all over, and its availability. But only thing is that it gives the augmentation of cardiac output to 0.5 to 1 liter only. People who have an ejection fraction very low, like 10 to 15% or so, for them, there is an Impella. Impella is a centrifugal pump, and it's available in 3 modalities, 2.5 to 3, CP, and 5. The disadvantage is that it requires a very large excess site. It does decrease the preload, but it increases the afterload because it injects the blood back into the aorta. It improves the coronary flow, decreases the pulmonary capillary wedge pressures, and it decreases the left ventricular and diastolic pressures. I would not like to go into the details of all those things, but these devices are within the realms of the experts who have used them repeatedly, and those people who have been trained adequately to use these devices, because they require continued monitoring and a good care. Otherwise, the complications are not uncommon: limb ischemia, bleeding, aortic dissection, and thrombocytopenia and whatnot. And most importantly, all of these devices, all of them, in them, aortic incompetence is a serious contraindication, because they keep on injecting the blood with the pressure to tissue perfusion in the ascending aorta. All right, the implantation of left ventricular assist device. The patient must have no pulmonary vascular resistance elevation and should have a good right ventricular function. People who have a not adequate right ventricular function or an abnormal PA pressure, then they will not benefit from left ventricular assist device. True, many a times left ventricular assist device, when implanted, the right ventricular dysfunction secondary to left ventricular dysfunction continues to improve. But in that situation, therefore, one must be extremely meticulous to find out that the pulmonary vascular resistances are not high, and the back pressure, pulmonary artery pressure, is due to the back pressure of elevated left ventricular and diastolic pressure. Exact, precise hemodynamics must be determined before implementing such expensive and exact. Okay, so the indications are bridge to transplantation, bridge to recovery, and destination therapy. Now, this is the Intermex score, and this is especially Registry for Mechanical Assisted Circulatory Support mentions that the 1-year survival can be improved even in a serious most patient, and especially those who are class 1 and 2, or those who are in class 3 and 4, to an extent of about more than a year. Now, the heart transplantation, I think there is a separate talk about the heart transplantation, and therefore I would not go into the detail, but I think just only it is really a very good device. I've known of 2 cases in whom the heart transplantation has been done twice over a period of 12 years and another 10 years. Quality of life is 4+, functional status is improved remarkably. 1 year survival today is more than 90%. Median survival is approximately 12.2 years. Please note that when evaluation, do take care of psychological and financial factors too. Commonest cause for transplant is ischemic cardiomyopathy and dilated cardiomyopathy, and rarely the other causes like valvular heart disease, congenital heart disease, and there are several retransplantation also. And finally, the waiting list for the transplant is very, very big. Donors are scarce, and therefore one must use it in a selected cases for whom there is a reasonably good future life, active life, and therefore usually below the age of 60. And finally, hit hard and fast, correct all reversible causes, ischemia, non-compliance to medicine, infection, and whatnot. And it requires a team approach for selecting advanced therapies for right patient at right time. Thank you very much.
Thank you, Dr. A.B. Mehta, for a very, very excellent, lucid, detailed presentations about the changing scenario in the treatment of the heart failure. Now I would request Dr. Divakar Jain to introduce the last speaker, Dr. Praveen Chandra from Delhi.
Thank you very much, Dr. Mahapatra. This is a wonderful session and the speakers have been phenomenally good.